Since we have a very packed agenda for today, I would like to start the forum. So, hello and welcome, everyone. My name is Rodrigo Scutini. I'm the Executive Director of the Infectious Disease Alliance. I would like to extend a warm welcome to all of you here today. Welcome to the Infectious Disease Alliance first virtual forum. So, the forum's topic on global infectious disease policy priorities was chosen some months ago in the early stages of this event planning. Now, in light of the drastic changes in global healthcare landscape that happened over the course of the few last weeks, this topic carries a whole new importance. So with the US signaling enormous cuts in funding and plunging the field of international aid and global health into uncertainty and instability, it's more important now than ever to keep our policy priorities front and center. So what are the new possible routes we can take to face those uncertainties? How can we plan for a global health system that is equitable, sustainable, and efficient? Today, together with you all, I hope to discuss some of those strategies. So the agenda will be as follows. So we have an opening remark from myself. Then we have 8 note speakers speaking for 5 minutes each. We'll have a thematic group meeting for 30 minutes, dividing the participants into breakout rooms. Then we'll have a thematic report from those groups for 20 minutes so that we can learn the results of those discussions. Then there'll be discussions on the policy priorities on the IDA strategy that was sent as a pre-read for this meeting, and some closing remarks. So, well, for those who don't know IDA yet, so we are an organization working on global policy, public health advocacy, and representing the voice of civil society on infectious diseases. Our vision is to ensure a world where the burden of infectious diseases is significantly reduced, and our mission is to unite civil society around those joint actions. So what we do, so we advocate for impactful policies and sustainable finance. We unite civil society to combat infectious diseases. We promote healthcare systems in strengthening. We foster cross-sector collaboration and One Health. As well, we promote equity and amplify the voice of underserved communities. So what we offer to our members and in general for our stakeholders, so access to critical tools and networks, opportunities for global alignment, advocacy and policy support, partnership building with diverse group of stakeholders, and resources for capacity building and innovation. So why the Infectious Disease Alliance? So it's the opportunity for a joint representation for civil society in an infectious disease space, unifying the fragmented community around infectious diseases, bringing accountability to policymakers, ensuring that infectious diseases are on the top of the policy agenda and finance, as well as promoting exchange, knowledge sharing, and collaboration among our stakeholders. The members for the Alliance are civil society organizations such as NGOs, professional societies, scientific societies, patient organizations, and research institutions. Supporters are in the kinds of foundations, private sector, and governments. And the engagement partners are the ones we kind of do advocacy work towards, which are international organizations, policymakers, and governmental agencies. Our committees, where our members are, dividing their attention and where we plan our events, are around the following areas. The first 8 ones, we call them specialized committees, which focus on, specific disease areas. And the last 6 ones are around cross-cutting areas such as One Health, digital health, gender, and climate change. This is our, the framework for our policy strategy. You have seen this on our website. We'll be discussing this later today in one of the last sessions. So the main, idea of it is to have an organization that facilitates civil society efforts to contribute to the achievement of SDG 3.3, which is our strategic goal. Then we have our impact goals, which are to, represent CSO voices, promote access prevention, and the strengthening of healthcare systems. Our external pathways and internal labors are here as well. We are very welcome to have your inputs and further in the discussions. You can give that input in the breakout rooms regarding the area you will be assigned, but also in the last session about the general discussion about the strategy. So due to the changes in international, policy and finance regarding the US freeze of foreign development aid, the whole of the global infectious disease community has manifested strong concern on this. So that's why we are running a culture action on preserving global health security through sustained investment in infectious disease prevention and control. So the US decision has severe implications in terms of shutdown in disease surveillance in 60 plus countries, disruption of vaccination for 50 million children annually, and loss of healthcare workers and early warning systems. It really matters. It's really an important aspect for the global community. And we are calling through this culture action, the US government and the US authorities to restore global health funding immediately. So if you agree with this culture action, please go on the website and sign it and join this initiative. Now, without further ado, I'll give the word to our speakers. Maybe Lucica is there for the first speaker.
Yeah.
Are you? Yeah.
Yes, I'm here. I don't know if you can see me or hear me.
We can. Thank you, Lucica. I'll give the floor to you.
Okay, thank you very much. Thank you for the introduction. Thank you for inviting us. Thank you for allowing me to speak. We have a big meeting at 3 o'clock here in Geneva, so I have to quickly run to that. First of all, my name is Lucica Dițiu. I am the executive director of the Stop TB Partnership. We are a UN-hosted entity pushing forward to end the TB globally. Very impacted, as many of other partners, by ourselves, but more important, the TB response by the new vision of the new US administration and the way that is going ahead. The impact, as we all know, are heavy at country level, and the over-dependence on delivering services, including very small services, including delivering drugs, including running diagnostics of people with TB, are in several of the TB high-burden countries highly impacted because people salaries that came from US are not paid, so people are not there. So we observe a huge impact on this, and it will be translated because it's TB, it's airborne, on more transmission, on people developing resistant TB and people dying. Even before this conversation here, we discussed at our board in Abuja with the ministers of health that we have in our board, India, Indonesia, Nigeria, Philippines, and South Africa, about which they committed themselves about owning their TB response and about smart investments, because that's what it is about, smart investments in TB and in health. Because as we know very well, there are many situations that are, the domestic funding is not enough to cover the health priorities of a country, especially in countries that are high burden of diseases and low income. I think the US hit an already underfunded sector, as you said, the infectious diseases, not always the darlings of the domestic budgets. I think the countries are now realizing the very challenging situation of depending on the US. But I also want to tell you that what we observe from every country we speak, there is no desire in going back to ask US for, funding, okay? People are realizing that each country should take care of their own citizens. And it's a very difficult ask for a head of state or government to go and say, please, President X or Y, give me money to treat my people. Similarly, I think, I don't think this is the purpose of this discussion, and I know I have just 1, 2, or 2 minutes more. I want to say that realistically, I don't think that the global health architecture will look the same after this spring, okay, from May. I don't think there is any, I think that personally, my opinion is the new administration doesn't have much appetite to continue funding big multilaterals or organizations here in Geneva or elsewhere. I think there are a lot of things that were not necessarily going very well in different directions. So I don't think that there is too much scope of reversing this. They might go into supporting different countries, but in a bilateral manner, and of course, discussing what's in it for me, I would say. We are devastated because it's not just is not about our staff here in Geneva, which we will of course look at a very dramatic cut. It is a lot about our partners on the ground. We as Stop TB have hundreds of grantees funded by US and French funds. French funds are continuing, but for US, our grantees, which are all civil society grassroots organizations, around 200 active, they all are stopped the work, and they are all those that provide services in terms of access to treatment, in terms of adherence to treatment, diagnosis, prevention, and so on. In terms of the policies or forward-looking, here having a large group of people, we should look into whatever smart ways of coming together, integrating some of the services and or a lot of them, looking at what can be done at national and subnational level, and how countries can be advised or supported to increase the funding that they have for health, and especially for the infectious diseases, as you said. Is not the time for individual diseases. It's looking at the overall budgets and how it can be done in such a way that through one intervention you can benefit several. You know, diagnosis, there are now tools that are multi-performing for different diseases. That should be encouraged to happen. Delivering of treatment can happen in the same time for several other diseases to the extent possible, and so on. So there are a lot of smart ways that we can look at it. As you rightly said, probably the agenda would have looked different if it was not for the last 2 weeks in terms of the conversation, because now, if there is anything that we need to look at, is how at country level some services need to be resumed, that at least some people get diagnosed and some people get continue their treatment without us, observing an entire disaster for, I would say, the infectious diseases that were unfortunately over-dependent on the US funding. So we from Stop TB, we can work together on whatever. We are trying very much to put together evidence for the impact. It's devastating, it's depressing, it's very upsetting, but we will have to go through it, and we need to see how we can support countries and governments to go through it, reducing the reliance on the external funding, because that hits very bad back. So that's what I wanted to say, and thank you very much.
Rodrigo, you're muted.
Rodrigo, you are muted now. You should.
Rodrigo, you're muted.
Thank you very much, Dr. Lucica Ditiu. It shows more than ever that the united response to the situation is necessary at this moment. And yeah, and thanks for sharing the perspective from the Stop TB partnership. So for the next speaker, I'll give the word now to Dr. Chantal Morel from the KPM Center for Public Management, University of Bern. Over to you, Chantal. We cannot hear you very well.
Not hear very well. Okay, hold on. Okay. Do you hear me now, and do you see my slides?
Yes.
Perfect. Okay. Hey, everybody. I'm Chantal Morel. I'm an economist specialized in antimicrobial resistance. I'm just going to make a few points on well, I've been asked to talk about policy priorities and AMR. Just like our previous speaker, we're at a bit of a special time, of course. With regard to AMR, though, in particular, it's as if we had a decade of quite strong policy development from many different angles. So strong policy development, but now we're heading in more into the phase of implementation. And this is really where kind of the funding situation is making things a little bit shaky and a little less certain. So as we all know, almost all countries now have a national action plan for AMR in place. It's been agreed. But only about 10% of countries have the funding to actually fully implement their plans. So I'd say it's the implementation of the policy phase. The implementation phase of the policy is a little uncertain at this point. Now, there's also, in terms of the innovation policy, so we've been playing with the right policy approach to support R&D in the AMR space now for about 15 years. And we have some quite good ideas put forth, and there is a relatively, pretty strong consensus around these approaches. But it's really uncertain now whether those are going to move forward at all. So, of course, there's the Pasteur Act that has been sort of floating around in the US Congress. And now one could sort of guess that probably it's the last thing anybody is thinking about. So, yeah, don't really know where that one's going. Also, of course, for R&D, we expect in the US that NIH will have a hand and BARDA will take up sort of later development initiatives. I'm not really sure where that is right now, but again, I can imagine that's also has a big question mark over it. What is promising, though, is that it does seem like Gates might be stepping in to fill some of the gaps left by some of the big US organizations. So, for example, some of you might have seen just this morning, Gates having a call out to fund therapies for gram-negative infections. So, yeah, let's hope that sort of attempt to fill the gaps will spread to other areas in AMR. On the European side of things, they are about to launch the new partnership, the new European Partnership for One Health in AMR. That should happen this spring. That's much more promising because in this case, it's the member states who are continuing to fund AMR initiatives and research, but with a 30% top up from the European Commission. So there's real potential to be, to have more scope than previously. Now, I'd say we still have some structural issues that we need to deal with because it does feel like we're heading into a phase politically, at least if Europe follows the US, where policy will be driven a little bit different. So it really will be seen as, only responding to the will of the people. So rather than necessarily what the science is saying, rather what political leaders are hearing from the population. A slightly different approach, of course. But this is not, AMR is not an obvious thing to respond to in terms of the public. It's, we call this a silent pandemic. It's not your usual disease or condition. It's hard to internalize. So if we expect the push to come from the population, well, we probably won't hear it at political level. It's also, of course, something that's very difficult to quantify and to communicate around. We're talking about the biological change within a pathogen that previously was susceptible to an antibiotic that we had. So it's not something that's very easy to understand and to communicate. It's also difficult to understand in terms of the economic impact that it has. That's something that I work on a lot. Again, not easy, and we shouldn't expect that it'll be then picked up within sort of, the push from the public. Does that mean I have to wrap up? Sorry. Is it what the beep is? Anyway, I'll try to be quick. Also, coming at this from a One Health perspective, very much needed. At the same time, we need to be aware of the ways in which it creates quite a blunt instrument. So, for example, in surveillance, many countries want to tackle this from a One Health perspective, but they lack the IT systems or the health information systems to do so. And so they almost think, oh, well, we can't tackle it from a One Health perspective, so maybe we just don't tackle it at all. When in fact, choosing any of the sectors to improve surveillance would have value. And then finally, also, when we talk about capacity building, so policies aimed at creating capacity in country to maintain the momentum that we have in AMR research and improving policies, etc. We tend to fund a fair amount of research, so small amounts of research, but in terms of the longevity of the workforce within this area, it doesn't really match. Like, academia is not set up really in a way that accommodates One Health yet. Whereas academia still has everything, disciplines that are much more narrow. So it's difficult for people who are specializing in One Health to then create careers out of it. So yeah, again, some tricky bits with going at this from a One Health perspective. Then finally, just a word on IDA. So very, welcome to this alliance. Very happy to have you in this sphere. I had a look at your strategy, and I'd say that the timing couldn't be better to be working on equity and access, to building bridges across the various policies, national, regional, global level, and of course, trying to unite the CSOs that work in the infectious disease space. So a very warm welcome to IDA. Thanks very much.
Thank you very much, Chantal, for your kind words and also for your analysis on the current situation. Yes, you're a bit behind time, so I'll invite now Jeremiah to speak. So Jeremiah Mangwani from the World Heart Federation is going to speak about the intersection of infectious diseases and cardiovascular diseases. Over to you, Jeremiah.
Thanks. And I think you guys are controlling the slides for me, right?
Yeah.
Great. So hi, everyone. My name is Jeremiah Mwangi. I'm the Director of Policy and Advocacy at the World Heart Federation, and really appreciate the invitation from IDA to speak today, because I think it's not often that the NCD or long-term conditions community works also with other different global health communities. And I think now more than ever has kind of been highlighted by previous speakers. It's going to be critical that we are working and finding those synergies and, as you say, building the bridges. Next slide, please. The World Heart Federation, so where I'm from, is an organization. We're an association, so we're a membership organization made up of cardiology societies representing the professionals working in cardiology and heart foundations around the world, as well as patient groups. So we're really looking at translating the science into policy and then supporting and elevating the voice of cardiovascular disease in global health discussions. I think that when we think about CVD on the next slide, obviously, we know that CVD is the leading cause of death globally, responsible for over 18 million. And I think probably most people, when they think about cardiovascular disease, think often of the risk factors such as smoking, physical activity, some of the lifestyle risk factors as they are sometimes known, and less so about the role that infectious disease plays in heart health. So I think just, thinking about the fact that chronic infections drive inflammation, that they accelerate atherosclerosis and cause damage to the heart and blood vessels, and that this is a consideration, particularly where we see an impact, and I'll show in a couple of slides later, that in lower middle income countries bearing a burden where untreated infections are leading to lifelong cardiovascular complications. So we really think about, how do we integrate infectious disease prevention into cardiovascular health strategies? How do we work together? It's not something that as a community we are it's not obvious. I think people have worked typically in different silos, and so we also call on all the members of the alliance as well to think about how we can structure ourselves and collaborate more in the future. On the next slide, you can see some of the different infectious diseases that are related to cardiovascular disease or linked. So, for example, strep infections, which lead to strep throat, and then rheumatic fever, which can damage the heart valves and leads to rheumatic heart disease, which is a major cause of death in many low resource settings, particularly in the poorest, most vulnerable populations, impacting children, teenagers, and young adults, and creating significant complications, for example, in pregnancy. We have conditions like Chagas disease, a parasitic infection, which can lead to heart failure and arrhythmias in its chronic stage, and often the work in that area has operated in quite different segments where the cardiovascular community sees the late stage consequences and hasn't been necessarily involved in the advocacy related to containing the parasite and the infectious side. So again, opportunities to bring those communities together. Influenza and COVID-19 and significantly increase the risk of heart attacks and strokes. And so that just really points to the importance of vaccination in preventing cardiovascular complications. And then the last one around infective endocarditis and bacterial infections of the heart valves and the life-threatening complications that leads to. So bearing this in mind, on the next slide, you can see really the diagram on the right really shows all of the different factors that are involved in this case, particularly Chagas disease. So we know that there is a considerable intersection of risk factors that amplify CVD risk, from poverty, the social determinants of health, challenges around screening and diagnosis. We seem to have gone back a few slides. And so I think that just generally points to the need for this holistic approach, but also the fact that if we try to do everything in one hit, sometimes that can be quite complicated. So just finding those ways of working together, is it that different people are working on different components, but then there's a mechanism for interaction or discussion. Sometimes there's the ambition of having just one plan or one approach, which can be just very complicated and hard to bring about given budget cycles, policymaking processes, and so forth. So finding that way of collaborating again. On the next slide, you can see some of the things that we really want to see prioritized if we're to tackle cardiovascular disease. I think a lot of the scene setting of this conversation today is about the latest in geopolitical changes and in fundraising and funding. But say, for example, from the NCD world, I think that the latest figure was that around 2% of ODA goes to all NCDs. So that's cancer, cardiovascular disease, diabetes, etc. And so we're starting from a very low point. And clearly it's not about now, especially particularly necessarily arguing for more funding specifically to say NCDs or CVD, but looking at the health system elements that we need to strengthen and how we can do that in a coordinated way. So I think we all share probably this focus on primary prevention, on diagnosis and treatment. How are we delivering services that cover the broad spectrum of health? I mentioned, vaccination being such a critical tool, and how the cardiovascular community is a strong champion for the drive around vaccination, but also thinking about then the delivery of care when we know that people are impacted, say, with rheumatic heart disease. So my last slide, I think, just to go back onto the policy priorities. So strengthening infectious disease surveillance with Chagas disease and rheumatic heart disease, we still struggle around fully understanding the burden of the disease. Expanding universal access to vaccines, stronger primary healthcare systems, investment in neglected diseases. I think a big focus of the SDGs is addressing equity, and two of the big neglected cardiovascular diseases. So as I mentioned, Chagas and rheumatic heart disease both have a significant equity dimension to them, and they often get neglected and left behind. And then just looking at how we continue as a community to bridge kind of this gap that still, to me, seems there in terms of NCDs, infectious diseases, and other areas, and making that work together. And I think, for example, the previous speaker talking about AMR, this is a big challenge for us in rheumatic heart disease, where strep throat is the major risk factor, trying to talk about access to antibiotics and encouraging governments to be providing that access also raises questions around the supply chain issues, and then compliance, and then risks of antimicrobial resistance, and how we navigate that space. So I think that's all of my points very quickly delivered, but just to say that we're very supportive of this opportunity to connect with you and talk about how we address these conditions. Thank you.
Thank you very much, Jeremiah, for joining us from UN Building in Geneva. Thanks for taking your time for this forum, and I wish a great continuation in your meetings today. Thanks for that. Now we'll be joined by Guilherme Faviero from the HF Global Public Health Institute, speaking on global health governance. Hola, Guilherme. I hope you're there. And
Yes, still here. I'm here.
Over to you.
Thank you. I would like to begin by thanking Rodrigo, and I think you're still on the window. Oh, there you go. And the Infectious Disease Alliance for the invitation to address you here today and briefly speak about our work at the Institute. My name is Guilherme, and I serve as the director of the HF Global Public Health Institute at the University of Miami. At the Institute, we work to enhance international health law, policy, and governance through applied research, analysis, and advocacy. We do this through a multidisciplinary team of analysts and researchers with backgrounds in medicine, public health, public policy, and academic research, and also through a network of experts and thought leaders with whom we collaborate regularly. I myself am a regulatory attorney by training with a focus on FDA regulatory law and the life sciences, and I hold graduate degrees in biomedical sciences and public health. Our work at the Institute is to generate evidence and use that evidence to develop advocacy strategies that we execute with our country teams located across 4 continents, with the ultimate aim at making a contribution to improve global health governance, strengthening public health law, and advance global health equity worldwide. The AIDS Healthcare Foundation is a global nonprofit organization that serves over 2.2 million people in 47 countries. We are a self-funded organization in the world's largest provider of HIV/AIDS care in the world, where we provide cutting-edge medicine and advocacy regardless of ability to pay. At the Institute, however, our focus extends beyond HIV and AIDS, and it's geared towards improving, as we said, public health and global health policy worldwide. So how did we become involved in this line of work? Well, during the Ebola outbreaks in West Africa in 2014 and 2016, AHF lost 2 of its doctors, which forced us to ask questions about the impact of such infectious disease outbreaks on our capacity to serve our patients, and also on the capacity of the global health system as a whole. This spurred efforts to develop evidence-based approaches for our advocacy to enhance and improve public health emergency response anchored in equity and cooperation. The Institute's work began in collaboration with the Harvard Global Health Institute in the aftermath of Ebola. And after Dr. Julio Frank, who was then dean of the Harvard T.H. Chan School of Public Health, when he left the university to serve as president of the University of Miami, we then established a formal institute at UM and this is the institute that I now direct. Since before the inception of the COVID-19 pandemic, we have advocated for an international agreement on pandemic prevention, preparedness, and response to address critical gaps in the global health security architecture. In response to COVID, our institute commissioned a study that was published in the Lancet Public Health titled A Global Public Health Convention for the 21st Century. And this served as impetus for a series of projects that we have since had, which included the launch of a collaborative effort called the Global Public Health Convention, an independent coalition of global health leaders, which is under the leadership of Dame Barbara Stocking, formerly at Oxfam, and also led us to now established a public health policy lab at the University of Miami, which functions as its main research arm. During the COVID-19 pandemic, in addition to advocacy and to research, we also initiated a SARS-CoV-2 genomic sequencing fund, which from 2021 to 2023 sponsored 15 projects in 14 countries and significantly boosted genomic sequencing capabilities worldwide with a focus on low and middle income countries. Presently, we have three core priorities at the Institute, which is concluding a pandemic agreement, which is reaching the final stages of negotiations in Geneva. We also have a focus on global health financing. And excuse me for 1 second, my notes have locked. Okay, so we go without notes. So as I was saying, our focus is on concluding a pandemic agreement at the level of the WHO. We also focus on global health financing efforts. We support the work that's done by the Global Fund, and we have also been advocates in improving the functions of the pandemic fund, which was created during the COVID-19 pandemic. Most recently, to enhance the capacity of regions, we have turned our focus to projects geared at advancing regional strategies for not only pandemics, but also public health emergencies responses in all continents. And we are currently conducting a study at the University of Miami, or out of the University of Miami, with global health experts who are making recommendations to enhance these capacities. And throughout this year, we are expected to host summits in Africa, Latin America, and Asia to help advance this conversation. In a world where we have seen a retraction of global cooperation, we hope that by fostering regional strategies and by creating regional unity, we are able to more effectively address these health emergencies, which impact not only regions, but the world at large. So thank you.
Thank you very much, Guilherme, for sharing the priorities for the world and also for AHF Foundation. Has been very insightful. Thank you very much for joining us from Miami today. So I would like to move now to our next speaker, which is Dr. Marcus from the Global Health Technology Coalition, which is one of our members at the Alliance. So over to you, Chrissy.
Thanks, Rodrigo. Can you hear me okay?
Yes.
Okay, great. And you'll advance my slides, right?
Yes, exactly.
Okay, great. All right. Thank you so much. Good afternoon. Good morning, everyone. Christy Mikes, Executive Director of the Global Health Technologies Coalition, or GHTC. It's really a pleasure to speak with you today and share some insights into the challenges and opportunities in driving innovations for global health and how GHTC works to enable progress through policy. So for those who aren't familiar, GHTC is an advocacy coalition that really works to advance policies to accelerate the creation of new drugs, vaccines, diagnostics, and other tools to advance global health. Next slide, please. Just a little bit about our coalition. Our coalition is 50 members strong and includes nonprofit product developers, advocacy organizations, academic institutions, and aligned businesses. And we focus foremost on biomedical innovations and their role in combating neglected and emerging health challenges. Next slide, please. So why do we need innovation? Why do we need R&D? As many of you know so well, research and development is foundational to solving the world's most pressing global health challenges. New technologies have driven tremendous progress in global health, from the near eradication of polio to changing the trajectory of the AIDS epidemic to driving remarkable declines in child mortality. Yet, despite all of these technologies, millions of people still suffer or die each year because we don't have enough technologies and the right technologies to combat many longstanding and neglected health challenges. And new threats are always emerging at a rapid pace, as the previous speakers have already mentioned, due to factors like increased human mobility and climate change. Next slide, please. Just taking a look at some of the challenges. As we look across our sector, there are many significant obstacles to developing global health technologies. Most notable is the lack of traditional market incentive. Emerging infectious diseases and health challenges impacting the world's poorest places offer limited profit incentive to spur private sector-led R&D. So you see this gap of investment. This means that public sector investment is critical to jumpstarting research and moving products through the R&D process. And it was very, very helpful to hear our speaker from the Stop TB Partnership, Lucia, talk about the challenges of US support for this. And we couldn't agree more, being based in Washington, DC, but it remains a significant barrier in our area. And while we were fortunate to see a trajectory of growth in public spending on R&D for neglected diseases from 2015 to 2019, according to Impact Global Health's G-Finder report, public funding has been on the decline since then. And in 2023, it reached its lowest level reported since 2015, as many of the largest donor countries have seen political shifts and reoriented focus on domestic concerns. And we saw that COVID-19 really just exacerbated that. So it really is a challenge that we're all having to deal with. We also need a paradigm shift in how innovators and funders think about access from the very start of the R&D process. It's just not enough to simply design a technically effective health product. That product must also be what we call fit for purpose to reach rural and last mile settings globally. Given so much R&D is driven from high income countries, this is not always top of mind. It's usually getting the product out, but thinking about access in those very early stages is absolutely critical. Another challenge is R&D capacity gaps. Under-resourced health systems in lower and middle income countries can increase the difficulty of conducting clinical trials and securing regulatory approvals, as well as facilitating access through local and regional manufacturing. Next slide, please. So we'll talk a little bit about the policy enablers for innovation. Policy change is a critical lever to overcoming these various challenges. And there are steps policymakers can take to accelerate the development of promising global health technologies. And that's what GHTC is focused on making happen. So just at a high level, first, we need policymakers to increase public funding for R&D for neglected and emerging health challenges, and ensure that that funding is predictable and sustainable rather than driven by panic and neglect cycles, which it often has been the last few years. At GHTC, our advocacy focus in the United States works to increase or protect US funding for global health R&D across contributing agencies, including the NIH, USAID, BARDA, DoD, and CDC, and a few others, in advancing creative ways to funnel more dedicated funding directly to this work through legislation and congressional directives. As you can imagine, given the last couple of weeks, we definitely have our work cut out for us in making sure that that work continues and that funding remains strong. Second, we need to strengthen local and regional R&D, regulatory and manufacturing capacities in lower middle income countries so that products can reach patients faster and countries and regions have greater control in ensuring product access. In our multilateral advocacy, so we work with US advocacy and multilateral advocacy, we're also working to advance R&D strengthening provisions and commitments through the World Health Assembly, G7, G20, and other multilateral initiatives like the Pandemic Accord and Pandemic Fund. We've also been successful in advancing reforms to streamline the pre-qualification process at WHO. Some of you may know that it's a regulatory certification process that helps facilitate production, introduction, and access of that product worldwide. And we work with countries in the global health security agenda to help develop a soon-to-be-launched tool to support countries in how they assess their R&D capacity as they identify gaps in need in their own country. And third, we need to embrace innovative approaches and technologies to drive efficiencies and lower the cost of R&D so our investments can go further. For example, AI holds promise to deliver efficiencies in drug discovery, as well as preclinical and clinical research. And finally, as noted, we need to design for access from the very start of the R&D process. So at GHTC, we like to talk about the 4 A's for access. Can the product be made at an affordable price for lower and middle income countries? Can it be made less challenging to administer or utilize? Can it be better adapted for health systems with limited infrastructure? For example, places with unreliable electricity or cold chain challenges. And how will it achieve availability at scale? So at GHTC, through our advocacy, we've sought to ensure that those principles are better reflected in the strategic approaches of research funding agencies like BARDA and USAID. And we're really excited that we have this new partnership with IDA. We think the GHTC and IDA partnership will be more critical than ever to continue this arc of progress, even though there remain significant challenges. And just last slide is really a thank you so much to Rodrigo and the fabulous IDA team for the opportunity to share some of these perspectives with you. And I look forward to continuing this discussion in the breakout sessions. Thanks.
Thank you very much, Christy, for an inspiring presentation. I like the 4 A's framework. I think is something the community could look more into, and thanks very much for that. Now I'll give the word to Dr. Erta Kalanji, joining us from Cameroon. Meredith Erta, the word is yours.
Thank you. Can you hear me?
Yes, I can hear you.
Yeah. So just a small correction. I am based in Abidjan, in Ivory Coast, not Cameroon, but an equally lovely country. Yes, hi everyone. Thank you for the opportunity, Rodrigo, to be able to share some of our thoughts on global health priorities today. So I represent One Health Trust. We are an organization that works on global health issues, most of which have been mentioned today. We have a strong focus on infectious diseases. So COVID-19 and malaria are 2 examples. We also have a very strong line of work on antimicrobial resistance. And we continuously work to sort of address issues such as pandemic preparedness that fall within pandemic preparedness, health system strengthening, etc. This is just an example of some of the projects we have running in Africa. We are based in both India and the US, but our projects are mostly spanning in low and middle income countries across Asia and Africa. So at One Health Trust, we like to take a One Health lens to the projects. And I know that, and I recognize and acknowledge the comment made by one of the speakers today, that sometimes One Health really sort of makes things very complicated. But because we don't have the technology and the resources to actually investigate everything, simultaneously in all sectors. But I'd just like to explain what that means in our work. So we feel that that everything is interconnected. So if we care about health in humans, so human health, then we really need to also consider animal and environmental health. And so our focus is to really try to understand the impacts in the different sectors and the interplay, etc. So next slide, please. So when it comes to global health priorities, so this was something that that we discussed before agreeing to participate in this webinar. There are many of them, but we feel that several of the global health issues today are interconnected, and they fall within these categories of pandemic preparedness, so the ability for countries to become more resilient and be able to face future pandemics. That's a really important global health priority. Climate mitigation is another one that is this is something, the impact of climate change is being felt right now all over the world. But as we know, low and middle income countries are carrying the highest burden. So climate mitigation is a priority, especially in certain parts of the world. And then antimicrobial resistance control. That seems to be an issue that appears everywhere. And it really makes already existing issues worse, because antimicrobial resistance, in essence, what that means is that it really complicates not only infectious disease treatment, but also non-communicable disease treatment and therapies. So I know one of the speakers mentioned cardiovascular health, but cancer therapy, immunosuppressive therapies, and people with different immune disorders, they're all very highly vulnerable to antimicrobial resistance, and they really depend on antibiotics or antimicrobials that work. So we have to make sure that we keep these infections treatable. So at One Health Trust, a lot of the work we're doing really is focusing into like two main areas: preventing infections in the first place, and also access to healthcare. Now, these are very big words and broad. They have a lot of different aspects to it. But in a nutshell, we want to make sure that we improve life quality through preventing infections and improving infrastructure worldwide, and also having access to the right type of healthcare at the right time. While access to healthcare can be an issue of, let's say, delay in a high-income country, it may not exist at all in low and middle-income countries or in very poor and underdeveloped countries. So this global inequity really drives the issues that we have today, and we have to make sure that there are some basic needs that are met everywhere. I'll illustrate this with an example on my next slide. So in the spring of last year, in May, we launched the Lancet series on antimicrobial resistance for 2024. And there we really highlighted the power of prevention through improvements in infection prevention control at the hospital setting, improvements of water, sanitation, and hygiene infrastructure, as well as prioritization of pediatric vaccines. Now, these are not very complex solutions. These solutions already exist. And with these interventions or prioritizing these interventions, we could save up to 750,000 lives every year in low and middle income countries. Unfortunately, when we talk about infectious disease burden and all these global health issues we've been talking today, we talk about deaths and loss of life. And that's really something that we must work to reduce. But another aspect that we don't often talk about, because that's difficult to measure, it's the cost that this has on the morbidity related, or the burden with this disease, is the quality of life that is reduced, the futures that are impacted. So we have to understand that for every number like this, there are millions of people that are facing economic hardship or losing the quality of their life because of untreatable infections in the case of antimicrobial resistance. Next slide, please. Now, where is the problem? And I used antimicrobial resistance to illustrate this. The problem is that we have a lot of guidelines and there's a lot of evidence, a lot of research has been done, but implementation is really where the problem is. So if you think about antimicrobial resistance strategies, even though many countries already know what needs to be done, only above a little bit more than half of them have plans that actually have been approved or appropriated by the governments. And then even worse, only 10% are funded. So the reason why we don't see a lot of progress is because countries are not really investing on these issues. Next slide. So to sum up, oh, okay, this got a bit cut over here, but to sum up my little talk today, I would say invest in health. Investing in environmental, human, and animal health is really what needs to be done. So domestic investment for a lot of the health programs must become a priority. At the same time, better use of existing funding and integration of health programs to make sure that we make the most out of what is available is also a very good way to move forward. So that's it for me for today, and I look forward to the discussions later on. Thank you.
Thanks, Erta, for joining us from Côte d'Ivoire today, and thanks for the very good presentation on One Health and AMR. It's very insightful. There'll be soon in breakout rooms where you all be able to join some of our speakers and continue the discussions. So as next, we'll be joined by Sarah Collison from Site Savers. So happy that you were able to join this meeting. Sorry, I had some technical issues. Happy to manage. First, Sarah.
Hello, I hope you can hear me okay.
Yes.
I have a bit of background noise here, and as you said, I had some technical difficulties joining, so but glad that I'm here now, and thank you very much for the invitation. So yes, as Rodrigo mentioned, I'm from an organization called Site Savers, and we work in over 30 countries globally, particularly in Africa and South Asia. With sort of three main areas that we focus on. Neglected tropical diseases is a big programmatic area for us. We're also specialize in interventions and advocacy to prevent blindness and to promote eye health, as our name reflects, but we also have a big focus on inclusion and inclusive health services, which is some of really where I'm going to be focusing my comments today. We have a particular interest in inclusion of persons with disabilities in health systems and services and the associated inclusion challenges for that group, but always with a intersectional lens, which is to say that persons with disabilities will often be poorer than other parts of the population because of many sort of structural and social barriers and financial barriers that they experience. Many older people will have disabilities. Women with disabilities are particularly at risk in terms of their exercising and enjoying their right to health. So there are many linkages and relationships between different forms of disadvantage, even with the groups, persons with disabilities that we work with particularly. So the key area, we know, I think it's very familiar, we've been hearing just now about global inequities that are a big challenge in controlling infectious diseases. And we know, I think, and particularly was very, very clear from the COVID-19 pandemic, that epidemics and pandemics thrive on inequalities, and they also exacerbate inequities. And this isn't only between countries, but within countries. So I suppose it's quite link from what we've just been hearing about in terms of international inequities to then focus in on the importance of addressing inequities within countries. So just to kind of remind ourselves of what health inequities are, which is purposefully a different word from inequalities, because inequities in this space is understood as systematic, unfair and avoidable differences. And so sort of focusing on the unfair and the avoidable, these are things that we can do something about in the health status or access to healthcare for different population groups. And a lot of this is the result of differences in social conditions, which results in inequitable exposure or transmission circumstances when it comes to infectious diseases, often due to social determinants of health. perhaps inequitable susceptibility as well, where perhaps the nutritional status of a population group puts that group more at risk due to poverty or underlying health conditions, which might be, for example, associated with aging. And then a big area for the work that we do around disability inclusion in health is inequitable access to prevention, treatment and care in the health system itself. And sometimes, too often, that's a result of barriers in accessing services, and that may be in the public health sector, it may be also in programs delivered by development partners or with development partners. So yeah, these inequities, as I said, they're well recognized. But even with that recognition, the extent and the impacts of these inequities are still remain very poorly documented, not often very well understood, particularly with some groups over others, and disappointingly even less acted upon in a sort of deliberate and effective way. So if we can move on to the next slide, please. Just to kind of just paint a picture of those inequities, and I think it's important to remember that we're not only talking about a small percentage of the population. Actually, if you only take persons with disabilities, we're talking about 1 in 6 people will have a significant disability that could be associated with significant barriers in accessing healthcare. And this played out, we saw it in the COVID-19 pandemic, that persons with intellectual disabilities were actually 3.5 times more likely globally to die as a result of COVID-19. And a lot of that was due to discrimination and bias that led to denial of health treatments by service providers. We know that respiratory infections affecting children with neurological conditions will result in a risk of hospitalization of sort of 5 or 7 times what would normally be expected in children of the same age. And zero-dose children are known to come mainly from households where there are multiple and cumulative forms of disadvantage, which are also associated with lack of access to other essential services. And the list could go on and on. These are just a few sort of snapshots or examples of how these inequities play out. So if we can move to the next slide, please. So I guess that the message that we really wanted to get across today, just in the few minutes that I have, is to kind of really emphasize that while these inequities are really well acknowledged, and I'm sure none of this is news to most of the people on this call, we need to do a lot more to address them. That just, you know, the benefits and impacts of many of the health programs that we're involved in or that we're promoting will not automatically be equitable without really effective, deliberate action and investments to take on these inequities and tackle them directly. So in terms of what needs to be done, I suppose it's a very ambitious agenda in the sense that it kind of needs to be mainstreamed across everything that we do. And that's not just putting words in a policy document. It means actually saying, you know, in every part of a health program at every level, that health equity will be promoted and paid attention to. And to do that, it takes leadership from the top. It means that our own organizations and the organizations that we're advocating to and ministries of health need to take responsibility for this at the highest political level. And sometimes that requires a level of innovation and partnership that is new. And then you know, where there is a commitment, we need accountability as well to actually make sure that action is taken and that there is accountability for the progress made. And for that, we need to have much better data. And I think this is where a lot of the problems lie at the moment, is that sometimes the data that we need isn't, that itself needs investments and commitment to do that, collect it, use it, to even identify the inequities, the barriers and the risks for particular population groups, and to make sure that these barriers and risks are mitigated and reduced. And sometimes, well, normally one would need to tailor interventions and approaches for a particular context, and to do that it means working really closely with communities, with those who are most at risk of being left behind and being left out of services and programs. And probably something that applies much more across the board is that where primary health services are integrated and accessible to all and strengthened at that level, then marginalized populations will generally all benefit. So that focus on primary health care and strengthening integrated primary health services is absolutely crucial. So just to move to my last slide. So we're living in a time where some of the progress made is now being eroded for all sorts of reasons. Political reasons being the key part of this, and so we put a lot of emphasis on advocacy and holding governments to account to maintain and improve the progress that's been made so far. We also recognise and would advocate to everybody to take responsibility in your own programs, as well as making this a key priority and a responsibility for governments. And we would also say that without doing this and without making progress to address these health inequities, that key disease targets won't actually be attained, because we're not talking about a small part of the population. In many cases, we're talking about a very large proportion of the population that are affected by these intersecting barriers and inequities. So that's me. I hope that I more or less took the 5 minutes that I had. Thank you very much for the opportunity to share these thoughts.
Thank you very much, Sarah. It was also a very inspiring presentation from you, and for us, important to see your views on the importance of policy, finance, and data for tackling healthcare inequalities or inequities, as you say. We remember that. Exactly. So now over to Geoffrey Namara from the WHO Hub for Pandemic and Epidemic Intelligence in Berlin. So Geoffrey, we're going to speak about the importance of healthcare emergency preparedness. Thanks, and over to you. I hope we can keep to 5 minutes. Geoffrey, you have like a short schedule. Over to you. Thanks.
Sure, totally understand. And thanks, Rodrigo, for inviting us and your team for giving us the opportunity. So in the few minutes that we're left with, I'll quickly share about the importance of surveillance in health emergency preparedness and response. Can I confirm that you can see my slide?
Yes, we can see your slide. Yes.
Excellent. So previous speakers have talked about the recent events in global health, and what I want to highlight is the outbreaks, epidemics, and do not really follow the same line. Despite these events, they're continuing to happen and they continue to befall us. The WHO does regularly grade the emergencies across the world, and as of end of last month, we had over 30 graded health emergencies across 80 countries, across all the regions. The most recent being the Ebola outbreak within the country, within Uganda. And these outbreaks do cut across infectious diseases, as which is the focus of this forum, but also other areas, for example, conflict, displacement, that do have health implications. Now, colleagues on this group, I'm using the example of the pandemic, COVID, both before the start and during the pandemic, we largely had epidemiological data, our good old epi curves of cases and deaths. But I'm sure you had these other questions of, we would really want to, we were faced with the uncertainty, the radical uncertainty, and questions of what the additional insights we'd like to have that would have helped us understand better, either before, say, the pathogen, the severity of the disease, but even during the pandemic, we had various questions along the cycle of the pandemic. When we start lockdowns, many member states were stuck with these decisions when we had new variants come in. And what we learned from this, amongst other things, is the urgent need to not only look at what we traditionally have as surveillance data, but the importance of other data and the importance of collaborations in understanding this. So from that, we really appreciated the need for agility, for resilience, and for, say, the work of the IDA, the need for collaboration across all stakeholders to better understand, say, surveillance data to help us make better decisions. So key lessons around adaptability were highlighted in multiple documentation and reviews across multiple areas. And these challenges led to the establishment of the WHO Hub for Pandemic and Epidemic Intelligence that is based here in Berlin, in Germany. And one of the key approaches that have come out from this work is the collaborative surveillance approach that I will share very briefly about. So when we say collaborative surveillance, what are we essentially talking about? First, it is strengthening the capacity of our traditional surveillance data sources, integrated disease surveillance across many regions, but also strengthening the capacities across the other key data sources. For example, the One Health data sources, as my colleague Etta did mention about the importance of One Health, and more recently about laboratory work as well. So not only strengthening the collaboration, but also the capacity of these. But we've appreciated that this is really not sufficient. And what we now need to go to do in understanding this intelligence better is go beyond our traditional health sector and look at out of health, but health data, for example, border mobility data, for example, health capacity data, population insights from our vital statistics offices. Rarely do we look at this for pandemic intelligence. So a conscious effort to see how we can collaborate with them, not on the data, but rather collaborate actively to see what insights do we get from this. In addition to that, take it even further to look at other contextual data, for example, climate data, vector data. WASH is a key area that we've probably not been paying as much attention to. And all this will lead to, if we can do the collaborations with all these sectors, we get better insights that will help us and the decision makers across the member states to make better decisions. So this, we as the hub aim, we envisage a world really where we see collaborative surveillance, where collaborative surveillance is capacity and collaboration really strengthened, help to minimize the impact of these outbreaks, epidemics, pandemics to the communities and the member states. And to achieve this as the hub, we're essentially looking at catalyzing efforts across member states that help to strengthen this by three broad areas: connecting, innovating, and strengthening both the capacities, the coordination, and the collaboration such that we produce better data, better analytics, and therefore better decision making. The hub is achieving this through implementation of various projects across the three broad areas of connect, innovate, and strengthen that are all aimed at achieving our broad objective. With that, I'll say thank you and look forward to the further discussions on this. Thank you.
Thank you very much, Geoffrey, for your great presentation, and congratulations on your work from the WHO Hub in Berlin. With that, we have the presentations closing now, and the new session will be starting, which will be the thematic group meetings. You'll be allocated into breakout rooms, so the magic will happen, and you receive, you're gonna have like a window popping up on your screen. You have to click and it'll be allocated to that room. I would say that we have around 20 minutes for discussion, so by 10 past 4 CT, so in 20 minutes time, you'll be invited to come back for the plenary. We will not have a debriefing from each group. We'll skip that part. We'll send updates via email on those discussions, and we will jump at 10 past 4 directly to the overall discussions on the IDA strategy. So yes, now I hope the magic will happen smoothly, and remember, you just have to click to move. Yes.
Just opened all the rooms and people should be receiving them now.
Welcome back, everyone. I hope not too many conversations are abruptly cut. We're enjoying that in the One Health room. So thanks everyone for the active engagement, and we will now jump to the presentation was excellent. For the speakers that you still around, was very good. We were very inspired, and thanks also for staying over and joining the discussions. Now, instead of like debriefing all what we already discussed, we will do that through email. We're gonna jump now to the next session, which will be on discussing the IDA strategy. Maybe Sophie could share the link here in the chat. I mean, we're not expecting you to read and be able to comment the strategy immediately, but for the aspects you have captured during the during the presentations, but also my presentation in the beginning, would be great to have your vision. There was one specific slide with the framework. If you can look that in the document that we share in the chat, we will be happy to see your visions. And then we'll have the discussion here for more or less, 15 minutes. Yeah, Sophia just shared the link. So I'll keep here like 3 questions open for discussions. So the first one is, what is the most critical global policy priorities in infectious diseases that need to be tackled until 2030 that we as IDA can play an important role in? So I think Geoffrey, he said in his closing remarks about the need of coordination among various the disease areas. So would that be one of the policy priorities, increase coordination and collaboration? But I'll open to the floor for anyone who would like to ask questions, give comments, or make your points. Please feel free to jump in. No one so far. Maybe I can read some other questions to see if someone would like to jump in on something more specific. So, do the goals set in the policy strategy address the most pressing gaps in infectious disease prevention, treatment, and control? So, yeah. And our goals, as you saw, is to increase this voice globally, then to improve prevention and access, as well as strengthening healthcare systems. So the point about strengthening healthcare systems is very important, of not working in silos or in vertical areas, but like really improving what is really needed, which is the basic of healthcare delivery. Yes. Maybe someone is interested in jumping on this.
Can I comment? I think we need to maybe shed more light into this one, because the goals, I don't think so address the most pressing gaps. If you're talking about EDA's policy, I think maybe a little bit more work needs to be done on that aspect.
Mhm.
Yeah. Davidson has something to say.
Yeah. Anyone in the public?
Hi, Rodrigo. So you want like a brainstorm now?
Yes.
So we can help with the suggestions, what to focus in this agenda, right?
Yes.
So I'm also from Brazil. I work in Rio, in Fiocruz. So concerning infectious disease, we have lots of challenges, but considering I'm still understanding what the IDA purpose is. So as a civil institution, let's say like that, I think we could help in campaigns or concerns about the vaccines. We have a huge movement against vaccines, so we know that historically they are really important, really relevant. So actions in helping the continuation of the vaccines programs, for example, this could be one action. Another one is trying to help to map the gaps of treatments we have in different countries, in different scenarios. So many countries don't have basic antibiotics or antifungals. So I don't know if it's this way you're asking us to go with ideas. Sorry if I'm understanding wrong.
No, but it's just perfectly fine. Your input from a few clues, it's very important as well. So we will say a couple of words about the purpose of IDA. It's of course a global civil society organization, gather actors working on infectious diseases from the civil society space to kind of help align and coordinate action on the policy level for more direct, like active policies or attractive finance to those policies, as well as framing solutions and supporting also the members in strengthening their work. Yeah, so like really showing cases like we were mentioning, the lack of really basic material could be, it's in some contexts it's really key. And we're discussing with the One Health Trust about the lack of health information for the public is also an important topic that civil society could indeed play a role in, disseminating quality information on AMR, on vaccines, on prevention and so on. Yeah, exactly.
Rodrigo, we have a comment in the chat. It mentioned strengthening of weak health systems, building trust, improving access, addressing inequity.
Yeah, that's really great, and it also resonates with our strategy. So I think we're very well aligned there. Yes, coming from Cornerback. Anyone from the public? So don't feel shy. If you would like to share your ideas in text, it's also completely fine. Otherwise, feel free to raise your hand or just speak in. The last question I'm welcome to help to read it. So what are the key opportunities for cross-sectoral collaboration to strengthen global health systems and improve equity in infectious disease responses? So this question is more about the fact we're speaking about cross-sectoral collaboration, the fact that civil society could collaborate, and it does in many cases, with public sector, that we were speaking about with the individual from Fiocruz. And then, of course, the private sector can indeed play a role in that part as well. So, any experiences from the participants today on cross-sector collaboration. Mhm. So yeah, maybe we can continue with.
Fraser, sorry, Mr. Goodwin raised his hand.
Yeah.
Fraser, if you'd like to speak, feel free.
Yeah, I just wanted to say that there's a number of different issue areas where IDA can play a significant role, whether that's One Health and AMR and bringing groups together across a spectrum that's from environment all the way through to patients and communities. And then others looking at access to services and whether there is blockages or restrictions, and looking at how community engagement can solve that. But all of these issues, I think, have an overriding theme, and one that was brought by our first presentation very strongly is the great threat that's posed to all of the efforts that we've been undertaking, whether it's to do with AMR, whether it's to do with delivering universal health coverage, or whether it's to do with addressing health workforce shortages. And that is the threat of a sort of a populist right agenda from not just Trump. Us Europeans are very easily throwing the accusations across the Atlantic currently, but not very good at looking at our own house and what the problems that we have as well with that, and other world regions too suffer from it. So I think a great additional contribution that you can play is strengthening the role that civil society can play in rebutting junk science, in promoting evidence-based policy making, and the need that health has for real science-based answers that are known and that engage the community. And I think that's, as a strategic objective, an area where you can have a real added value, bringing in different world regions that have the same issue and face the same obstacles. And we see how Trump's impact has, what scale of impact this populist agenda has had to international collaboration and to science-based policymaking.
That's indeed a good point. Thank you, Fraser, for adding that, and the current risks in which is not restricted to US and Europe. I mean, that you can see in many other parts of the world, and the history comes in pendles, right, back and forth. So
yeah, but the West, as it were, has been very good at pointing fingers in the past, and is now not very good at admitting that it has its own problems. So that would be a useful dynamic to engage with.
yes, exactly. Thank you for that, Fraser. We also have a message here in the chat from Lara Perez Sanchez. She wrote that we need to focus our efforts also in migrating populations, which is of course a public health problem nowadays, and since they don't have a proper access to health and infection, increasing is among them. It's important to have proper antimicrobials and so on. So very important point, Laura, about migrating populations, and of course healthcare emergencies in that context as well. With that, I think it's about time that we jump to the closing remarks. So I would like to update the overall community about our next events. So those are physical events happening in the European Parliament. So the next one will be on the 14th of May on tackling vaccine hesitancy for Healthier Europe. Then we have the Danish Conference in Brussels as well on One Health which is also tackling the topic of health security. Looking at the role of Europe, of course, inside Europe, but as well as outside, in vision of, looking at today's discussion on the US taking a step back on this global role. What could Europe do for One Health? Then WHA side events, one on integrated primary healthcare for all and one on cross-sector collaboration, infectious disease management, both in May 25, and the last one on at UNGA that we're discussing with some partners on universal health coverage and health equity. So the list of webinars are here, they're extensive. Many of you have already registered through our website. You're welcome to have a look at that. We're covering a lot of those topics that we discussed today in the breakout rooms. Feel free to register and disseminate. Then, there are some projects we are launching and working on, as for example, the Infectious Disease Report, which is our annual flagship publication on policy science and disease trends. And the 24th edition will be published on September 10th of this year. Then we have our clinical trials dashboards, which is a centralized platform for global infectious diseases trial data. Will be launched in the middle of this year, focusing on giving access to clinical trials to individuals based in low and middle income countries, but also expanding the opportunity for researchers to collaborate with global institutions on clinical trials in low and middle income countries. Then we have the Global Infectious Disease Repository that will actually be launched very, very soon. It's our, repository of solutions, but also library of data guidelines and tools for the overall civil society community on infectious diseases. And yes, so a couple of words about a membership to IDA. If you're an organization in a civil society organization, you're welcome to join IDA. It's free of cost. You would gain representation in a committee related to diseases we mentioned. Then you can participate to events, get alliance updates, position your organization within the alliance, and thus also support our advocacy influence, also get partner updates, and support your organization with resources and in events. So thanks for joining this virtual forum to everyone. We had at the maximum about 80 participants, and now are ending with 50. It goes up and down. It's normal for this type of events. And we're looking forward to continue to this conversation with you. Look forward to meeting you in the future events. And please feel free to contact us for whatever question you may have. Thanks everyone for today, and have a great evening.
Bye.
Thank you. Goodbye.
Thank you. Goodbye.
Bye-bye. Thank you.
Thank you. Bye.
See you guys.
You too. Bye.
Thank you.